There we go.
Here we go.
Period.
Back on track.
Okay.
All right.
Baby.
Yeah.
All right. Back on track. So where did I leave off?
I think.
Oh, the developmental dysplasia.
Yeah.
Okay. Oh, after that, really?
Yeah, you
Okay.
started at, or you're at the section acetabular dysplasia.
Yeah. Acetabular dysplasia. Acetabular dysplasia describes a series of anatomic variants in the shape of the acetabular cup of the hip joint. Acetabular dysplasia is quite common in Europeans, with a prevalence of 3.4% in one large Danish series. Interestingly, the European population has also has a relatively high prevalence of the hip osteoarthritis. As early as 1965, it was suggested that variants in acetabular shape predispose to osteoarthritis of the hip. Several studies estimate that between 25 and 40% of hip osteoarthritis is attributable to subtle forms of acetabular dysplasia. Acetabular retrovision, in which the acetabular cup is posterolaterally rather than anterolaterally oriented. In one example of a type of acetabular dysplasia associated with hip osteoarthritis, an obvious question in light of this observation is whether changes in acetabular shape occur before or as a result of osteoarthritis. One study shedding light on this question was that of Reijman and colleagues, who studied 835 patients aged 55 years or older at baseline in the Rotterdam cohort for a mean of 6.6 years of follow-up, and found that the presence of acetabular dysplasia at a baseline was associated with an increased risk of incident hip osteoarthritis. Consistent with the idea that changes in acetabular shape predate the development of arthritis, Lane and colleagues found an association between mild acetabular dysplasia and incident radiographic hip osteoarthritis in postmenopausal women followed for a mean of 8.3 years. These studies suggest that dysplastic acetabular shape is a risk factor that acts together with a second factor, possibly age or a low-grade inflammation, in the development of osteoarthritis. Wagner and colleagues performed a case-controlled study with cartilage specimens obtained from 22 young adults, mean age of 30.4 years, undergoing surgery for painful femoral acetabular impingement and 6 age-matched cadaveric controls. They found that hyaline cartilage from case participants showed dramatically increased immunohistochemical staining for several markers of osteoarthritis. Let's see. Oh, damn, where did I leave off? That one's that. And collagenous cleavage product, as well as increased expression of collagen type 1 and 2 transcripts by in situ hybridization. These changes mirrored those of patients with advanced osteoarthritis. The study provides evidence that even in young adults without radiographic evidence of osteoarthritis, molecular changes in cartilage structure resembling those of advanced osteoarthritis are already underway. When present with other hip osteoarthritis risk factors, acetabular dysplasia may increase an individual's risk of osteoarthritis even further. For example, the combination of acetabular dysplasia and an abnormally shaped femoral head have been shown to increase the risk of osteoarthritis progression after surgical repair of the acetabular defect. In addition, despite inconsistent evidence linking body mass index to osteoarthritis of the hip, Reijman and colleagues found that patients with low BMI had an increased risk of incident hip osteoarthritis in the setting of acetabular dysplasia, though the clinical significance of this observation is not yet known. pistol grip deformity, and wide femoral neck. In addition to changes in the acetabulum, structural features of the femur have been linked to osteoarthritis. For example, a non-spherical femoral head produces the so-called pistol grip deformity, called impingement of the femoral head on acetabulum, likely the mechanism by which this lesion predisposes to osteoarthritis. The prevalence of pistol grip deformity has been estimated at approximately 8%, and this deformity may be more common in men than women. In a study comparing 1,007 cases with severe clinical and radiographic hip osteoarthritis recruited from orthopedic surgery, lists to 1,123 controls without radiographic hip osteoarthritis. Doherty and colleagues estimated an OR of 6.95 for the association between pistol grip deformity and hip osteoarthritis. At least 2 studies have identified a widened femoral neck as associated with hip osteoarthritis. Javed and colleagues examined, 5,245 elderly Caucasian women in the study of osteoporotic fractures with mean follow-up of 8.3 years, and found that wider femoral neck was associated with both prevalent and incident cases of radiographic hip osteoarthritis. The study suggests that femoral neck widening may precede or occur very early in the development of hip osteoarthritis. Alterations in femoral neck shaft angle. There is no consensus regarding the association of neck shaft angle and the development of hip osteoarthritis, with studies reporting ranging from no association to positive correlation between larger angle and smaller angle, or both, with osteoarthritis. During the progression of hip osteoarthritis, the femoral head flattens and the femoral neck shortens. Thus, the heterogeneity of results in studies examining a potential correlation between neck shaft angle and osteoarthritis may reflect the fact that this angle may change as a result of osteoarthritis, in addition to its likely role in contributing to osteoarthritis. Interestingly, Gregory and colleagues showed in prospective cohort that distinct differences in shape of the femur preceded development of osteoarthritis. In other words, differences in the shape of the femoral head and neck were present on pelvic radiographs before any detectable evidence of radiographic hip osteoarthritis. Furthermore, differences in hip shape present prior to the development of osteoarthritis predicted progression to hip replacement over the 6-year follow-up period, indicating that hip shape may predict the severity as well as the presence of osteoarthritis. Global shape of the proximal femur. The hip shape variants discussed above were generally defined using linear measurements measured manually or electronically on radiographs. In recent years, however, the techniques used to study the association between proximal femur shape and hip osteoarthritis have included ASM. In this method, a statistical model of the shape of an object is developed from a multi-point outline applied to measurements of proximal femur shape. This method has several advantages over traditional geometric measurements such as femoral neck length or width, as it captures a global representation of shape rather than a limited subset of components of that shape. Using this technique, Lynch and colleagues studied elderly women in the study of osteoporotic fracture population and found that variations in the relative size and shape of the femoral head and neck at baseline predicted incident hip osteoarthritis. Specifically, 3 distinct hip shapes or modes were associated with incident hip osteoarthritis, with ORs ranging from 1.73 to 2.31. The shape of mode 3, which accounted for the greatest amount of variability in overall proximal femur shape of the 3 shapes identified, was characterized by a larger femoral head size and a longer, slightly thinner femoral neck, reinforcing the idea that hip shape changes predate the development of radiographic hip osteoarthritis in many cases. Conclusion: the shape of the arthrodal joints is determined by a complex developmental program and by dynamic remodeling process in adult organisms. Joint shape appears to be an important determinant of hip osteoarthritis, and joint shape in turn altered by the disease process of osteoarthritis, leading to an intricate interplay between joint shape and arthritis. Molecular links that shed light on the nature of this interplay have surfaced in recent years. Future research, including the development of increasingly sophisticated analysis methods for human genome-wide association studies, will likely continue to illuminate mechanisms for this relationship and perhaps will point to methods of disease prevention or treatment. The end. Oh God, that's a lot. All right. So thoughts on osteoarthritis?
Okay,
Shape
so
like the
how do
huge-
we want to break this sucker up?
I could definitely take the first 2 or 3 paragraphs or points. I mean, I don't mind that. Like how many things are there, right? Like,
I think there was like 10 subheadings. Hold
like
on.
there's like 10 subheadings, right? So I mean, we could divide like what, 2 between each of us because there's 5 people here.
5. I thought there was only. Oh my gosh, there is 5. I don't know how to count, y'all.
You just didn't count yourself. That's why.
Yeah.
I don't know how they let me into
Yeah,
school.
we have Zoom user and Diamond Connor here.
Right, for real. Yeah, we can do 2 each.
Okay, I can take.
I could do the first 2. I don't mind that. I mean, there's really
I
like
mean, I talk about conclusion and global shape of the proximal femur.
that could work.
I'll do the 2 above it.
Okay, so let me write this in the Google Doc.
Yeah, so we don't forget. And then I'll do the 2 above that.
And I only know
And-
the 2.
So you're gonna do abstract.
What's that?
And the introduction.
Yeah, I mean, I could do the abstract and introduction, basically just like get it kicked off, you know?
Okay. So is intro and abstract. Okay, what did you say you were, Vivian?
I guess he's gonna do the
The
2
2
below.
above your conclusion.
So
Like
pistol
whichever
grip
ones you're
and
doing, I'll do the ones above that.
alterations. Pistol grip and alterations is above that.
Yeah, I'll do those 2.
Sayari. Which ones
And
did you say
then-
you were doing?
I'll do the acetabular dysplasia and then the developmental dysplasia of the hip.
And then, you
Yeah.
are gene environment and bone morphogenic.
Yeah, that'll be Eileen. And then I'm gonna do the introduction and the one right below it. The osteoarthritis of the hip is common and highly heritable.
You started. Okay. Prepare for discussion. That's what we're doing now. We put that part right on the Google Doc.
Yeah.
So at the video, we start again.
You're cutting out a lot.
Now,
Whoa.
She said, did it kick y'all out? No,
No, I
it
didn't
didn't
think
kick us out.
No.
okay.
All right, so yeah, I was just
We'll
saying
talk
like
more tomorrow.
we'll talk more tomorrow in
Goodbye.
class, right? And that'll be
Okay.
that.
Is that all the sections that we assign? Does everyone have Okay.
Yeah, everyone's
Yes.
got like a section.
Cool.
Check the
And
Google
then-
Doc on your section.
Yeah,
All right.
Google Doc, just make like a small little note of what you're going to be talking about and just try to like, make that into like a 7-minute digestible presentation, like a mini presentation, and everyone just like goes afterwards, and then, we'll just have fun with it, I guess, whatever that looks like
Hmm.
in the library on Saturday.
Yeah, sounds good.
Sounds great, right?
Okay, see you
Yeah.
guys in class tomorrow.
All
Stay
right, see y'all
warm.
bright and
There you
early.
go. Stay
Wait,
beautiful.
do we have to wear professional dress to this?
Probably not. I doubt it.
Okay,
It's
just
a
to
tough-
maintain
Sorry.
professionalism. I'm like, I don't know about.
Should we low key and make us look really good?
Okay, Vivian.
All right, you can come professionally dressed.
It's just because I have to.
Just
I
you,
have
though.
my
Yeah, you can
stuff-
dress up
wait,
if you
listen to me,
want.
Listen to me. It's because I have my stuff steamed because I thought we were gonna have to do the interviews for my sorority, but they got canceled. They got pushed back a week. So like, my
That's your
stuff is
chance.
just pressed.
This is your chance. You can show up if you want to.
No, it's okay. I'll come in a nice sweater and some jeans. Thank you.
Right,
I'm gonna come in
right.
with Crocs. I'm good. All
All
right.
right, bye
y'all.
guys. I'm about to take a nap.
Bye, y'all.
Toodles.
Diamond, don't forget to do your stats quiz.
No promises.
That's your grade, boo. All right, bye.
All right, bye.